And now we have time for questions. Ramin?
I have a question for choriocapillary studies. So Rick or Diego, you can answer. So how to be sure that the images we have are really representative of the reality or what's in the choriocapillaries? Let's see that you have some drusen or something on the top, and then you will have some void area because it decreases the signal, and then you will find a correlation between void areas and AMD, which is not an issue. Anyway, you show that you are able, from looking to that, to have a prognosis. But in terms of understanding, it's an issue anyway. So always I have this problem of being sure first that the images are the reality before we go to study. So what do you have any guarantee about that?
Go first.
I'll let you respond first.
Oh,
okay.
So in my study, I excluded patients with drusen just because of that reason. There are ways of getting rid of that image. You can divide the choriocapillaris image by the structural OCT image and kind of normalize the decrease in signals so that the choriocapillaris image is brightened in the areas underneath drusen. And if you see flow voids or structural voids in the choriocapillaris at that point, then you can compensate for that. But in my study, like I said, I did avoid drusen just to avoid that problem at all. Pseudodrusenoids or subretinal drusenoid deposits don't block the signal at all, so that wasn't really a factor in that issue.
Did you use the swept source?
No, that first study was done with spectral-domain. But it's the same thing with swept source.
Same thing? Do you think that there's no difference? No.
Well, swept source is better able to penetrate through drusen, but still, the point that you raised is valid. You know, it depends on what kind of segmentation method you used, and sometimes you look at some people, they say, well, we compensate for drusen being present, and then it looks brighter underneath the drusen than it does look elsewhere, so you can tell something's not right with the way they're doing it. But.
Thank you.
We also excluded the patient like you did with shadowing effect. So
Speak.
Okay. I was saying that we also excluded patients with shadowing effects over the capillaries. So that's how we managed the problem. Okay.
Dr.
Thank
Ono.
you.
Sui.
I'm Kyoko from Japan. I'm very impressed with Professor Ogura's 3D view of retinal neovascularization. And in that view, retinal new vessels seem to originate from large retinal vessels and not capillaries. And my question is that, have you seen other patients with retinal new vessels and whose vessels come from large vessels, not capillaries?
So you're talking about the case with the
Yes.
BRVO?
BRVO.
Yeah, that case, the neovascular vessel looks like comes from the large vessel because there's no capillary in that area because of the vein occlusion.
Yeah, I'm very impressed, and I think it is a powerful tool to determine the origin of new vessels, and I'm wondering if there is any difference between other retinal neovascular diseases like diabetic retinopathy. So thank you very much.
Back in the old days of looking with fluorescein, we saw neovascularization come from big blood vessels, not from capillaries. It was kind of unusual. Once in a while, you'd see a report of like new blood vessels coming from the foveolae vascular zone or something like this, but most of the time they come from big blood vessels. Then the weird thing, though, is often they come from veins on fluorescein on diabetics. I don't know if you ever noticed that. So that's hard to figure out how that happens, but that's just what it looks. Who's first? Well, Magdi has a microphone, so just for, okay.
Thank you very much. I would like to also ask Dr. Agura, on the same day you also performed two analyses with OptiView and ISSOCT, and what are your observations between them, especially on capillary non-perfusion areas and detecting microaneurysms that we have too many diabetic populations regarding the treatment options.
What was the question?
What are the main difference between the two devices? I mean, OptiView and ISSOCT.
Okay. Like I presented, all patients received ST-OCT, and only 1/3 of the patients received Topcon swept source OCT. So 130. So, and for the detection of the capillary non-perfusion, almost same. And for detection of a microaneurysm, I think ST-OCT is better than SSOCT in this particular patient. But the numbers is very small for the swept source.
Okay, thank you.
Can I just ask you a little question?
Yeah.
You said that, say, fluorescein had a sensitivity, ICG has sensitivity, OCT had a sensitivity. Yeah. But what was the gold standard? Was finding it on any one of them enough to make
we excluded. We excluded when all three modality cannot find anything.
Okay, but what was the gold standard when you said, say, fluorescein was 90% sensitive in detecting capillary non-perfusion, or it was actually lower than that? Mm-hmm. What was that 70% compared with what?
I think it depends on the lesion. I think for capillary non-perfusion, I think deep capillary plexus by OCT angiography, it was 100%.
Yeah.
So,
but the other ones weren't 100%.
Yes. So in case with CNV, ICG, when ICG finds CNV, and in that case, OCT angiography might not be able to find. So it's not 100% for 3 cases.
I see. Magdi?
My question to Dr. Martin about the PCV. You said that OCT-A is not yet reliable on detecting PCV. That's right. In your research, how often you couldn't find by OCT-A the polyp or anything? I mean, in our country, for instance, we don't have ICG. We are out of ICG. We don't do ICG anymore. So how much % we can count on if we don't have ICG, counting on only on OCT-A?
We can detect, we could not detect only in 4 out of 10 was detected and 4 was not detected.
So it's about 20 to 30%.
Yeah.
So,
yeah. But I didn't use the B-scan. If you have a PCV on B-scan, you can imagine you can have the polyps on B-scan is quite characteristic. So if you only use OCT-A, en face OCT-A, you find out the polyps only in 70% of the polyps. And the misdiagnosis was with CNV type 1 in AMD. We thought it was AMD, but it was polyps. We couldn't see the polyps. But I think with the improvement of the technology, we will be able to see them soon. I hope so.
I hope so.
Thank you.
We got a little competition here. We only have a couple minutes left, and we have a number of people arm wrestling to ask questions. So
just one
next
question.
up is Elaine.
Rick, do you think that these small flow voids in the choroid capillaries may be detrimental for oxygen diffusion to the retinal pigmented epithelium and photoreceptors?
Yes. Certainly the small ones, maybe not. But I think it's indicative of something that happens in your life, and you're kind of programmed to have these little flow voids and that they get bigger with life. Rob Mullins looked at the complement attack complex against choroid capillaris and found that that's what causes these blood vessels to shut down. But the curious thing, he looked at all age groups. It gets more with age, but it actually starts out when you're 5 years old. That's the earliest one he has, and already you're starting to lose choroid capillaris. So you're kind of almost programmed in a mathematical way to have this loss. And it's probably going on over your whole body in a sense, right? So that's what I'm saying. It has philosophical, implications. You think about that. You're programmed to fail.
May I ask a last question? Rick?
Yes.
So I have a question for all of you. So let's imagine that everyone gets rid of FA. So in what percentage of patients we will not have, with today's machine at least, reliable images on the OCTA, and we will regret having thrown out our FA? Because usually in the studies, when we do sensitivity or specificity or whatever, we just have a bar of quality. So say we excluded all the patients that have not enough qualities. Then when it comes to real life, we have to treat everyone, including those we excluded. So what's your opinion on what percentage of patients we still will need FA because we didn't have good enough OCT to make a decision? I know that nobody has the real answer, but have you an estimation about that?
Who will need? It's a difficult question because, yeah.
How about with a big PED, you're not sure if there's vascularized or not because the OCT
Yeah.
angiogram's not that sensitive. Are you going to do ICG?
I think
But sometimes ICG is not contributive.
Yeah, you can do
Maybe,
fluorescein.
maybe in pattern dystrophy, I think it's very useful to have OCTA, but it's the contrary. We don't need a fluorescein angiogram.
But try to think of ways where you really need FA.
Yeah,
I can come with big PEDs, but
big PED, yes.
Maybe.
Yeah.
blood maybe, I don't know. I can't really think of another.
but I think in 10 years, fluorescent will die.
How about you? You didn't say much. Tell us what you think about fluorescence.
I'm the youngest off the board.
We don't.
So you're probably the smartest. So in your lifetime, fluorescein, no more.
Yes, I hope so.
Do you think oximetry of the choroid is possible to compare the voids and the oxygenation of the choroid, for instance?
Oximetry currently uses the differential kind of absorption or reflectance of different wavelengths of light. And it's only good in coarser sized blood vessels. But you can imagine that maybe with adaptive optics or other things like that, particularly if we use fluorescence lifetime imaging where we can actually look at elements in the cytochrome oxidase or, the cytochrome sort of cascade that we can actually look at metabolism in individual cells, maybe at that point we'd be able to answer that question. All right, well, we're at the end of this one. Next up is Magdi Musa. He's taken over. He's going to be the moderator for next session. He's going to tell us about mystery retina.
Thank you.